Oi, Tiago. Boa noite, Rafa.
Estou conseguindo ligar meu vídeo. Estou proibido pelo host.
Tá proibido? Como assim? Thalita?
Não posso começar meu vídeo porque o host... agora o host me liberou. Obrigado.
Eu sabia que você ia estar chique assim, você não podia...
Ó, todo do jeito que eu voltei do hospital.
Não, é só São Paulo que o povo é chique assim, ó.
Hoje está frio aqui, né? Então o frio favorece.
Frio?
Deixa eu ver aqui, 20 e poucos, vai. Chovendo agora. Tem uma chuvinha boa, final de dia.
São Paulo é terra da garoa.
Ó, 16 graus aqui.
Tá frio, bem frio. Deixa eu só colocar aqui, compartilhar o slide. Ô, Tiago, então...
Só para a gente ver o formato, Aline.
Isso.
A minha sugestão seria eu e você fazermos a introdução e deixar o William tocar a condução da discussão, junto com os outros dois e a Márcia, só tentar conversar com ele para tentar com o tempo, né? Porque senão acho que muita gente também para discutir, a gente acaba se perdendo no tempo. O que você acha?
Acho que sim, o Gustavo, inclusive, fez aí o caso, né? O Gustavo Pena fez um caso clínico, mas o importante é a discussão, né?
Isso. Eu acho que faz a aula, a gente introduz, né, o evento, você, eu, e passa o chair para o William, e o William apresenta a Márcia e começa o evento, e depois o William conduz a discussão também.
Tá, eu queria só que você colocasse a importância desse capítulo de tireoide, qual que é a questão, né? Porquê do capítulo
Sim.
e tudo, né?
Não, tranquilo.
Pensa, eu acho que é bom você colocar também o que você pensou para organizar o capítulo, né? Essa questão de como organizar, que você pensou dos eventos periódicos e tal, aquela ideia que você teve.
Uhum.
Tá, então...
E aí depois você também pode complementar, tá, Aline? Se faltar alguma coisa que você julgue.
Eu só vou abrir, falar do grupo, porque tem uma turma, principalmente a turma do endócrino, que não conhece.
Boa noite.
Oi, Gustavo.
Tudo bem, Aline? Tudo bem, Tiago? Boa noite.
Tudo bem, boa noite.
O Gustavo, o Tiago, foi talvez que startou toda essa confusão, né? Que a gente se coloca, mas a gente adora confusão. Então, acho que a ideia é lançar com o pé direito, que a gente possa aí ter os tempos e Gustavo, o Tiago vai te falar. Claro que a gente tem uma coisa de Minas, Tiago, que a gente está tentando se organizar aí para ter reuniões em Minas periódicas, mas eu acho que tem a nível nacional que o Tiago vai coordenar essa parte aí.
Ótimo.
Do capítulo, né?
A ideia da gente é fazer algumas reuniões periódicas, envolver endócrino, cirurgião, medicina nuclear. Acho que tem bastante tópico multidisciplinar que a gente pode abordar em câncer de tireoide, né? É um protótipo da interação multidisciplinar. Então, a Aline, quando ela lançou esse embrião, achei que realmente é uma ótima ideia e eu acho que é um gap. Acho que a gente tem que conversar mais com as outras especialidades. a doença está ficando mais complexa, então acho que vai dar bons frutos aí ainda esse ano e principalmente para o ano que vem.
Ótimo, exatamente. Eu acho que essa participação aí de todas as especialidades na abordagem da doença tá mudando, né? A abordagem do câncer de tireoide vem mudando, principalmente desses tumores avançados, radioorto-refratários, então precisa de discussão mais ampla mesmo. E que bom que vocês estão animados também, eu acho que vai ser muito legal.
Perfeito. Aline, William, Márcia, está todo mundo ok já?
Eles confirmaram hoje, ela falou que entraria 15 minutos antes.
Tá.
Eu estou pegando aqui o link, que, como sempre, a gente faz a inscrição aí, mas o link às vezes não abre, sabe?
O que me enviaram por e-mail foi tranquilo.
Chega por e-mail, mas algumas pessoas não recebem, entendeu?
O William também confirmou, né?
Confirmou.
Deve estar para entrar já.
Eu vou mandar aqui o link, porque... Então, só copiar aqui, porque tem algumas pessoas falando que não estão conseguindo. Espera aí, já te envio. Que não estão conseguindo entrar pelo link, eu vou mandar aqui.
Acho que você mandou um link agora, né?
Esse é o link de inscrição, né? O link de inscrição é bom, porque às vezes participa aluno e tudo, e eles gostam do certificado. Olha o William. Oi. Não, é o Zoom. Não tem Google Meet, não. A gente nem trabalha com Google Meet.
Boa noite.
Noite.
É o Zoom. Eu estou te mandando aí o link direto agora. E olha aí, olha. Você quer que eu te mande por e-mail? Eu te mando nesse minuto. Tá, nesse minuto, tá? Só um minutinho. Só resolver aqui que a Márcia não confundiu e está entrando com o Google Meet. Não é Google Meet, é Zoom.
Estranho, né? Acho que em nenhum momento foi Google Meet, né?
O William falou que alguma coisa, que em algum momento ele mandou algum Google Meet para ela, mas nem tem Google Meet, nós não temos Google Meet. Ah, tá, entendi. Você está baixinho, William. Você está muito baixinho, a gente não está te escutando. Não precisa de password. Estou te mandando agora, nesse minuto.
O link que eu tenho aqui entrou tranquilo. Mandei aqui para o William, vamos ver. E ele está em contato com a Márcia, né, Aline? William.
Tá, ele está direto com a Márcia.
Perfeito.
Tá no seu e-mail, William. Acabei de enviar. Isso, tem tudo. Eu me atrasei toda também hoje, foi um dia caótico aqui no meu lado. Seu som tá bem baixinho para mim, William. Tá para você, pessoal? Ah, William, você tá comigo no som aqui, por isso que tá, desculpa. Você tá comigo.
O William não está online, acho que o William está no telefone ali.
Desculpa.
Ó, a doutora Márcia entrou.
William, que você tá no telefone, eu tô te caçando no Zoom.
Hi.
Hello.
Espera lá, entra lá.
Hi, Dr. Bruce. How are you?
Hi.
Hello.
Hello, Dr. Bruce.
Can you hear me now?
Yes.
Yes.
Yay. The link for the Zoom was truncated, so it wasn't working.
Okay. Now it's
I only
working.
got like 5 letters instead of the whole thing.
Okay.
Hey, Marsha, how are you?
I'm good. Hi.
Good to see you. I apologize for all the confusion. I thought that you were probably in the middle of your move and that these emails were going back and forth. So I apologize for that. But we're so happy.
That's fine. It's totally fine. We got there eventually and I'm all ready. So I think we're okay.
All right.
Hello, William.
Hey, Thiago, how are you?
Fine.
William, você estava no telefone e eu conversando com você, te procurando no Zoom. Eu quase morri de rir. O Thiago me chamou.
I was having issues with the Zoom link myself also, so I was calling everybody and I just finished cleaning some big mess today. But anyway, we made it. So, Aline, what are we supposed to do? You're going to introduce everybody? How are we going to do it?
We'll just start now. We have here, this is our agenda.
Good, né?
Só pedir para os moderadores, para o
difícil.
host aí,
Vou lá
montar
agora. Fico sexta, sábado e domingo pelo tempo. Vamos lá. Vai pra guerra. Tchau.
Aline, é a Thalita que tá?
Thalita que tá.
Thalita, tirando, então, Aline, eu, quem tá com a câmera aberta, os outros podem ir mutando, tá?
Isso.
I'm sorry, my
Oh, Márcia. Márcia is without.
Yeah, no, it's okay.
do you want me to start? I don't know Portuguese. So
No,
I'm not sure.
not yet.
Oh, don't worry.
Yeah, we're just gonna passing through the agenda for today.
Okay.
So, William, Aline is gonna do a little introduction, followed by me, just to introduce the chapter of thyroid cancer. And after that, I'll pass to you. You're gonna chair the meeting and present Dr. Bruce and the other panelists. Then after the lecture from Dr. Bruce, you conduct the discussion. We have one clinical case, right? So we're gonna have one clinical case to be discussed, and just take a look on the time. We're gonna try to end at 9:30 tops, right, Aline?
Yes. So I think we can start. It's already 8 p.m. Então, pessoal, Márcia, I need to speak in Portuguese.
That's
so,
okay.
Okay?
I trust you.
Ok. Pessoal, sejam bem-vindos a nosso evento. É com grande honra, né, que a gente tem aí o objetivo principal hoje de lançar o nosso capítulo de tireoide do Grupo Brasileiro de Câncer de Cabeça e Pescoço. Dr. Márcia, welcome. This webinar is to celebrate our new chapter of Brazilian Group of Head and Neck Cancer about thyroid cancer. It's an honor to have you with us this evening. And Antes de tudo, gostaria de que vocês soubessem assim, quem é o Grupo Brasileiro de Câncer de Cabeça e Pescoço. Nós temos vários colegas aqui que já conhecem o grupo, mas é importante a gente falar para os novos colegas, os endocrinologistas. O Grupo Brasileiro de Câncer de Cabeça e Pescoço é uma organização multiprofissional, não apenas de médicos, mas de nutricionistas, fonoaudiólogos, dentistas. E esse grupo, a gente criou ele em outubro de 2017. O objetivo principal é cuidar de todo o ciclo de cuidado, né, do paciente com câncer de cabeça e pescoço no Brasil. E a gente trabalha em 4 frentes, que é a conscientização da população sobre o câncer de cabeça e pescoço. A gente faz campanhas nas mídias para a população saber sobre o câncer de cabeça e pescoço, suporte aos cuidadores e pacientes, e educação continuada para profissionais de saúde, que é um dos braços fortes. Esse capítulo é nesse braço de educação continuada, e a pesquisa clínica, que é um braço que está coordenado, que está o William, que é na linha de frente. O capítulo, né, de tireoide que a gente está lançando hoje, foi interessante o surgimento desse capítulo, que foi uma necessidade da gente, que foi notada aí por 2 colegas que estão aqui hoje moderando, o doutor Gustavo Pena, que é endocrinologista de BH, e o doutor Gustavo Meyer, que é cirurgião de cabeça e pescoço, e eles trouxeram para a gente essa demanda. Olha, Aline, a gente está precisando de discutir sobre câncer de tireoide. E aí veio aquele clique, né? A gente fala muito de carcinoma epidermoide, mas a gente também tem que trazer para a mesa o câncer de tireoide, que a cada dia mais a gente está vendo essa necessidade de um braço dedicado a esse tipo de tumor, que envolve realmente uma equipe multiprofissional. Então, esse é o objetivo. A gente tem a doutora Márcia Bruce. Eu passo, então, para o Tiago introduzir sobre o câncer sobre o capítulo de tireoide, para depois a gente passar para a doutora Márcia Bruce. Tiago, por favor.
Obrigado, Aline. Então, boa noite a todos que estão acompanhando o nosso evento hoje. Então, a Aline já deu uma introdução em relação ao nosso grupo, o Grupo Brasileiro de Câncer de Cabeça e Pescoço, e também a gênese e a origem do capítulo de tireoide. Então, a ideia da gente investir neste capítulo é que a gente sabe que tratar câncer de cabeça e pescoço é multidisciplinar, então é um dos tipos de tumores, tipos de câncer que exige mais uma interação multidisciplinar, e com certeza no carcinoma de tireoide a gente vai ter um cenário que sintetiza muito bem essa necessidade de uma abordagem multidisciplinar. Então, aqui a gente vai ter envolvidos no cuidado do paciente, é o protótipo de um cuidado multidisciplinar integrado. A gente vai ter envolvido desde radiologistas que fazem ultrassom, radiologistas intervencionistas que vão fazer punções aspirativas, biópsia, endocrinologistas, cirurgiões de cabeça e pescoço, oncologistas clínicos e médicos nucleares. Então, a ideia desse capítulo é trazer todas essas especialidades para que a gente sente, para que a gente discuta conjuntamente vários aspectos do tratamento do câncer de tireoide. Então, a ideia é envolver não só oncologistas, cirurgiões de cabeça e pescoço, endocrinologistas, mas também médicos nucleares, radiologistas, ao longo de um programa com encontros periódicos, né, especialmente no próximo ano. Então, esse é o lançamento, a gente está tendo esse primeiro encontro, a ideia é ter mais um encontro ainda esse ano, e ao longo do ano que vem a gente desenhar um programa com encontros periódicos ao longo do ano, tentando abordar diversos tópicos de câncer de tireoide. Ainda mais agora que está sendo adicionada toda uma complexidade aos tumores de tireoide pelo surgimento de novas drogas, novos alvos potenciais. Então, isso traz também muito combustível para a nossa discussão. Então, basicamente, era isso que eu tinha para falar. Gostaria de convidar, então, agora o Dr. William, que é oncologista clínico, diretor da Oncologia Clínica da BP, Beneficência Portuguesa de São Paulo, que vai ser o chair do nosso evento, para conduzir aí e agradecer. I'd like to thank Dr. Bruce very much. It's an honor to have you here talking with us. And William, the stage is yours.
Well, thank you very much, Thiago. I'm going to speak in English. First of all, I would like to thank Dr. Rose for kindly providing some time to discuss with us the past, the present, and the future of thyroid cancers. It is an honor For those of you who don't know Dr. Bros, she's a leading expert in the thyroid cancer field. She has led many clinical trials that led to drug approvals in this setting. She has a lot of experience, and I think we're going to learn a lot from her. Dr. Bros, it's an honor to have you here. Congratulations on your new job at Jefferson's, and please, we're looking forward to listening to your talk.
I think, yes.
You're muted, Dr. Bros.
Yes.
Does that look okay?
Yes.
Yes.
Okay. Okay, great. All right. So, not that I have like 4 hours to speak. I'm going to do the past in a much condensed way, even though there are a bunch of slides, but I'm not going to spend much time on them because most of this data has been out for at least 2 or 3 years. And I just wanted to get it in there because there are just a couple little details that I'll touch on because I think that they're things that directly lead into what I'll be talking about today. But it's really my honor to be here. I'm very honored to be in Brazil. I tell you that about 6 hours ago, I was in the UK. So I guess, well, wonders never cease. I never could do that before. So here we go. Slightly different talk, but let's do it. So I've been working with a lot of different companies, so I'm hopelessly conflicted, but having a good time with all the clinical trials. So treatment strategy. You know, when we didn't have any therapies, there was no treatment strategy to be had. And you were lucky if you had one thing to give these patients. So now we have questions like, which do we do first? Which do we do second? So before I get into the story, I'll introduce you to our actors, our main players. So we have 2 therapies that are FDA, EMA approved, lenvatinib and sorafenib for advanced RAI refractory differentiated thyroid cancer that is progressing. We recently have 4 new, what? Oh, I'm sorry, I thought I heard something. 4 new highly selective inhibitors, 2 that target TRK fusions particularly, larotrectinib and entrectinib, and 2 that target RET. So for RET fusion differentiated thyroid cancer, and that's selpercatinib and pralsetinib. And those are now also approved by the FDA for solid tumors that have those gene fusions. Then finally, not so new on the list, is the agents that target the BRAF V600E, vemurafenib, which was worked on in 2012, and more recently dabrafenib, which was shown to have results in 2019. So these are the players, and now we have to understand how are we going to figure out what we do first, what we do second. How do we build an algorithm for our treatment sequencing for our patients with RAI refractory differentiated thyroid cancer? Well, I'm a student of a pretty famous oncologist. His name is Dan Haller. He was the editor-in-chief of the JCO for at least 10 years. I'm not quite sure exactly how long. And he really is a clinical trialist and taught me basically everything I know. So I will give it to you from the purist standpoint and how we use clinical trials to inform our clinical decision-making, especially when the data is not necessarily something that we can compare side by side. So the first question and biggest question is, how do we sequence these kinase inhibitors? We have sorafenib and lenvatinib that were the first FDA and EMA approved treatments for the RAI refractory thyroid cancer. No requirement for any genotype, all comers. These 2 agents have been proved effective in large phase 3 studies. And these large phase 3 studies have the most information on the dosing, side effects, and the design was done across multiple sites. We don't have to worry that there's bias because it was really international. So really seeing this data was really universal. And so these are the 2 I would argue that came in first. And I'll just go quickly through the data. This is the sorafenib data, the design, 1-to-1 randomization, RAI refractory patients who had progressive disease in the year prior. Primary endpoint was progression-free survival. Secondary endpoint, overall survival, safety, and response rate. So this was the first curve to show any benefit. It was back in 2012, and it showed basically that placebo arm progression-free survival was 5.8 months, and the sorafenib arm was 10.8. And why that's important is that the hazard ratio is 0.587, showing that this was clearly an efficacious agent with a p-value of less than 0.0001. First of all, the endocrinologist will tell me, oh, you don't have to treat thyroid cancer. Well, that's clearly not true. In our patients who have stopped taking up radioactive iodine or take up radioactive iodine and still progress, we showed here that those patients in the placebo arm would progress in 5.8 months. These are not patients that are going to sit around for a long period of time. These are patients who are RAI refractory, and also as eligibility for the trial, they had to have a lesion that was at least 1 centimeter, and they had to have progressed over the year prior, meaning a new lesion or a growth by at least 20%. So those criteria were enough to select the patients that had clearly advancing disease, as is shown by a PFS in the placebo arm by 5.8 months. So we don't have to overthink and wonder, oh my gosh, when do we start? When do we don't start? This data shows you clearly that those criteria are all you need to know for who should be treated. Okay, so I like to show the placebo arm almost more than the treatment arm. Of course, a doubling of PFS as the first try was a good result. The response rate in the phase 2s and in people who are more experienced is probably closer to 20%. But in this phase 2 across multiple sites, most of the sites had never given it before. The response rate was a little lower at 12.2%. And that likely has to do with people not used to doing it, managing the side effects, and we're dropping the dose maybe a little bit more than I do. But anyway, still a response rate and a large number of patients. If you look, 41% had either a response or stable disease for over 6 months. So clearly an active agent. Median duration of response was about 10.2 months. It took about 4 months or so for them to get to their responses. So this was clearly an active drug and definitely good for our patients. Side effect profile, almost all of them were grade 1 and 2, the exception being hand-foot skin reaction. Another side effect that was not the doctors were not used to managing was grade 3 and 20%. In the hands of experienced doctors, this is closer to 5%. Why? Because when people get hand-foot skin reaction, they always have grade 1 and 2 first. So if you jump on it and intervene at that time, either with a dose holiday or getting them to take ibuprofen, you can prevent 3 and 4 hand-foot skin reaction from happening. Again, look in the placebo arm. Look at these numbers in yellow. If this is the placebo arm, if all of these adverse events were just because of drug, then the placebo should have no side effects, but that wasn't the case. So what these numbers tell us is that these patients are symptomatic or became symptomatic while they were on study. And that's important because, again, many endocrinologists think, oh, you don't have to treat these patients. They're going to do well for a long time. Well, that's because 90% of the time these patients do well. But this study and the studies I'll talk about have selected the 10% of patients who need care. So please use those criteria so that you can identify the patients that need help before it's too late. So the second drug select was for lenvatinib, 2-to-1 randomization. This study was different because it allowed one prior VEGF receptor inhibitor. Most of the time that was sorafenib, and it's stratified by age. Same endpoint PFS, overall response rate, and safety, as well as overall survival. One more thing I'll point out is that this had a central review of the patients before they went on and was a little bit more rigorous. And for that reason, if we look at the placebo arm, now they're progressing in only 3.6 months. Technically the same criteria, except for the fact that we had a central review, and those central reviewers seem to be a little bit more rigorous or a little bit more strict than the physicians in the first study. But regardless, there's no question, nobody will argue with the fact that the lenvatinib arm really did great. 18.3 months of progression-free survival compared to 3.6 months. Hazard ratio, again, less than 0.0001, and hazard ratio of 0.21 and a p-value of less than 0.0001. So this was the basis for the primary endpoint being met and the approval of this agent as well in about 2014 and 2015. And what you see here is when we stratified it by patients who had had a prior therapy and didn't have a prior therapy, In both cases, these did well with progression-free survival of either 15 months or 18 months. Not a big difference for people who might have had a primary therapy before that. So regardless of whether you get your hands on this drug in the first line or in the second line, lenvatinib was clearly active. Now, the partial responses here were notable. 63% of patients had a partial response, and 2% had a complete response by RECIST criteria. None of these were really cures, but they were significant reductions to the point where it couldn't be measured. That said, these two together is really the basis why a lot of people pick this as their first agent. In addition, I'll point out that the time to the response was very quick, only 2 months. These patients did well, and they did well fast. The problem is that if you have patients who have invasion, either into airways or into the esophagus, trachea, or blood vessels, this rapid response could lead to perforations of different organs. So if people have invasion, I usually give them extra risk alert. I still have to treat them, but this is the only situation that I might start them in a lower dose and warn them that there could be devastating consequences if they do respond too quickly. So side effect profile, similar, look at this. The placebo arm is not zero. These patients are feeling fatigue, decreased appetite, nausea, vomiting. They are not feeling well, meaning that they are developing side effects, or they're developing symptoms of their cancer. And so again, these criteria identify people who need to be treated. I also want to point out that hypertension in this case was very high, grade 3 or higher, 42% of patients. I will say again, this was because most people had not given this agent before. If you don't anticipate there's a very rapid rise in the blood pressure and compare the patient with blood pressure medicines or well control their blood pressure before they start, you will be in trouble. So this is a very big warning sign, and anybody who gives this drugs needs to be aware of it, as do the patients. And they really should be getting their blood pressure done at home, but they should have a cuff that they should check it twice a day, usually for the first 2 weeks. So what else is a little bit more new? So this is a little newer, still 3 or 4 years old already. We see that lenvatinib also, when we looked at the stratification by age, which is a pre-planned analysis, lenvatinib improved overall survival in the patients that were over 65. So here you see the lower curve. That was how patients did in the placebo arm who were over 65. And you see this large improvement. And it basically gets rid of how badly the older patients did compared to the younger patients. It totally abrogates the difference, meaning that patients who are over 65 should definitely be treated with lenvatinib because this shows a clear overall survival, which was statistically significant. Interestingly, we didn't see that in the patients who were under 65. Remember that all of these patients were allowed to cross over at the time of progression, and most people progress by 2 or 4 months. So what this is actually saying is in the older patients, if they progressed, they had a more likely chance of succumbing ultimately to their disease. They didn't tolerate any progression well, whereas the younger patients sometimes could tolerate a little bit more progression before they got on an active drug. I do think in the long term that there will be an overall survival benefit to these agents, but we just can't prove it within the confines of a single trial. But this was the first time ever overall survival benefit was shown. It was shown in a population over 65. And many of my colleagues were saying that they weren't treating these patients out of fear of comorbidities and hypertension. So it just goes to show you that if you control the side effects, these patients actually benefited even more than the younger patients. This is the response rate. You can see the blue bars show that the 65-year-old and over responded quite well. And this is in spite of the fact that they had a slightly less dose intensity. Because of comorbidities, it was more likely that we had to hold drug or occasionally dose reduce them. But in spite of having less dose intensity, they still had a very good response curve. So what is the optimal sequencing for giving MKIs? I would say in conclusion that sorafenib and lenvatinib, which have both been FDA approved, can be considered in the first line setting. But given the overall response rate and the improved overall survival in the older patients, lenvatinib more often than not is used first. The exception, as I said, is sometimes if we want to start a little slower in people who might have invasion into the organs in the neck, we sometimes prefer sorafenib in those cases. Most of my patients will be treated by both. So I don't benefit by telling a patient that I like one drug and hate the other. What we basically need to tell our patients is there are two drugs, and based on various strategies, we may pick one over the other in the first line setting. But in the end, almost everybody will usually get exposed to both if it's available in your country, because we have one drug and it doesn't last forever. And when it stops working, we can use the other drug. So this is how my algorithm starts out: lenvatinib and sorafenib first line. So question 2, what's the optimal starting dose? So there's been a lot of controversy here. Because of that 42% of hypertension grade 3 and diarrhea and loss of weight and various things, a lot of the people who've been given this, many of whom are not necessarily oncologists, have made a big statement that they don't feel that you should start at 24 milligrams. And that especially the endocrinologists, who don't give toxic drugs quite as often as the oncologists do. But I think that we know that the best way to settle a question like that is with a well-designed clinical trial. So the question is the 24 milligram dose the best dose? Or if we started at a lower dose, would we be able to get the same efficacy with more safety and less toxicity on a patient-reported scale of quality of life? So this study was designed as a phase 2 randomized trial. Again, it was supported by ASI, and we randomized patients in a double-blind fashion. I can't say that enough. In a randomized double-blind fashion. In other words, the doctors couldn't be biased and the patients couldn't be biased. No one knew what dose they started at, but everybody was treated the same way. If they had a grade 1, grade 2, grade 3 toxicity, as always, we had guidelines, and you can look up the trials to see what the guidelines are for managing, say, hypertension, grade 1, 2, 3, 4, or any lab abnormalities or other things like fatigue, weight loss, or diarrhea, for instance. We're very aggressive with making sure we control the diarrhea with lots of Imodium, but we didn't know what dose they started at. Okay, so everybody's treated the same way. Okay, that's the only way we'll get to the answer: double-blind, randomized control trial. So in this case, the select case, we knew that 68% it had a grade 3 or 4 hypertension. Well, 68% had required a dose reduction when they started at 24 milligrams, and grade 3 or 4 hypertension was 42%. So again, double-blind fashion, 18 milligrams starting dose versus 24, looking at efficacy, safety, and patient-reported outcomes. So the design is on the next slide. Dose reductions, as I said, everybody was treated the same. And here we have the design. So we have patients randomized 1-to-1 to the different starting doses. Primary endpoint was the overall response rate at 6 months. It has been told to us that people felt that that was too short to look at a difference in the overall response rate, since we know that patients will continue to respond. And in fact, we know exactly how many. So we know 89% of patients will have reached their partial response by 6 months. So we're only missing an additional 11%. And we know that what their response rate is before predicts for how they do after 6 months. So the statisticians and the FDA felt that this was a very good endpoint. We did not need to go out a year. 6 months was a reliable endpoint to look at the difference. We looked at how many people had a grade 3 or greater treatment emergent adverse events in both of the arms. And then secondary endpoints, we still looked at progression-free survival, although it wasn't powered for that, because we already knew that it was active, and we looked for overall safety. Patients were assessed in the exact same way as they had been in the SELECT trial. And what was interesting was that as of week 24, the overall response rate in the 24 milligram a day starting dose was 57.3%, and it was 40.3% in the lenvatinib arm. These results failed to demonstrate non-inferiority of lenvatinib 18 milligrams. So that's not a complete surprise to the oncologists in the room. It's not unusual that if you use a lesser dose, you get a lesser response. And I think we could have predicted that. And so this basically shows it numerically. It also shows that there is, basically what we were doing is with a higher dose, we're getting a bigger response, really at the sacrificing more patients who just had stable disease. Higher stable disease here in 18 milligrams, higher partial responses in 24 milligrams. This was statistically significant, and therefore it was the primary endpoint was met, showing that 18 milligrams was not met, showing that 18 milligrams was not inferior, implying basically that 24 milligrams was better. Now, this is the, sorry? So this, we'll get to the questions in the end, but this was the, the visual of it. You can just see how many more patients were stable disease versus not in the study. Now, if it was that we just did overall response, then we would say that 67.2% being better than, I'll point out that people were treatment naive. They had 67 versus 51%. But even people who had prior therapy, they were still 50% versus 36%. So it didn't matter whether you're getting it in the first line or second line, it still resulted in a non-inferior, absence of non-inferior, 18 milligrams was not inferior. Okay, so I know it's a statistical way of saying it, but that's the correct way. So this would basically support 24 milligrams being the better starting, but that didn't answer the question, is it safe? And is it, how are the patients doing? Because what everybody complains about is, who cares if it's a little bit more efficacious? Because we feel like our patients aren't as safe, or we feel like our patients have a worse quality of life. But do they? So let's look at the data. Let's go to the videotape. This, by the way, was the progression-free survival, which I'll point out was not statistically significant, but you're already seeing a trend here to a worse progression-free survival in patients on 18 milligrams versus 24 milligrams. And if you look at this, now we get to safety. The percentage of patients who had a grade 3 treatment emergent adverse event was 61% versus 57%. This was not statistically significantly different. Very, very slightly higher number of grade 3s, but not clinically significant in any other way. No more hospitalizations, no differences in death. So basically, this primary safety endpoint demonstrated that as of week 24, instances of grade 3 or greater were similar in both arms between 24 milligram starting dose and 18 milligram starting dose. And it's not surprising that when we look, there's a slight increase in treatment, in duration of treatment as well, 11.8 months versus 9.1 months in the 18 milligrams. So these lower dose patients are on drug for less time. You would have thought if they were tolerating it better, they would be on it for a longer time, but they weren't because they were progressing sooner. If you look on the next line, this is the dose intensity, and not surprisingly, even with dose reductions that were required, patients who started at 24 milligrams had a higher dose intensity. And for all intents and purposes, this looks like it was clinically significant, resulting in longer treatment duration and in improved overall response rate. Of course, 77% it's lower here because they were more likely to have more than one dose reduction. So relative to the starting dose, the dose reduction was more significant in the 24 milligram. Plus 24 milligram, the first dose reduction went down to 18, whereas 18 went to 14. Okay, so here we have less dose intensity in the 18 milligrams, longer treatment duration in the 24 milligram arm. Finally, what's interesting is if you look at all the AEs across both, you see here that there's not a big difference. It's a little bit of a difference in the grade 3 hypertension. But interestingly, instead of 42, 45, 46%, I have it down here, I think. So instead of 42% in the SELECT study, we're already down to 25%. Why? Because the doctors on this study anticipated the hypertension, knew how to prepare for it, and were ready and prevented more cases of grade 3 hypertension. That's straight patient experience, physician experience in how to manage the side effects of the drug. So similarly to hand-foot skin reaction being better, this is also better in the subsequent studies. But what about quality of life? That's the last one, right? You're like, I know it might be safe, Dr. Brose, but the patients hate it. Or do they? This shows the two arms in the in some of the, there are three quality of life comparisons over time. This is the first one, this is the second one, and this is the third one. So you're not going to be able to say to me anymore that I start patients at a lower dose because the patients will tolerate it better. They just don't. Yes, it might require a little bit more attention from the part of the physician to manage the side effects and anticipate them. But if you do this right, with equal management, looking at the hypertension early on, being ready for managing these things, the patients report the equal quality of life on both starting doses. Okay, so now we really have the 3 important information we need. I'll point out that this last one was presented this morning in Europe. So how more current could you get in the talk? I just want you to know. So hot off the press, we have improved overall response rate, we have equal safety, and we have equal quality of life. Okay, so it's a little late here. I'm getting a little goofy, maybe, but it's important. It is so important. 24 milligrams was 17% lower in response rate than the 18 milligrams dose. Incidence of grade 3 or higher TAEs was not significantly different. Patient-reported quality of income is not significantly different. This supports that we should be starting every patient at 24 milligrams, okay? That's because we're not going to be biased anymore. We're going to actually use the data. Now, there are, as I said, exceptions. If I have somebody who has invasion into the trachea, into the esophagus, I have to be more gentle. I'll start then. If they have frank invasion on a scan, those patients get started at 4 milligrams or started on sorafenib because it's a little bit more gentle. But I have had patients who had invasion into the trachea with half of the trachea occluded by tumor. And I started, it was like a video game. And I started them on a half dose or quarter of a dose of sorafenib and very gently like dialed it up till the half of the esophagus opened up. But when it got to the edge of the esophagus, I stopped because I didn't want that plug to come out. And I managed a patient for over 3 years that way. Not ever having a fistula, but just gently decreasing the size of the tumor without having it go out through the wall. So that's a very, very special situation. If you ever want to talk to me about that, I can talk to you about it. I've done it about 3 or 4 times. And so that's the only case when I don't start at 24 milligrams. And that even means those 65-year-olds, okay, or higher. So then what's next after sorafenib and lenvatinib? Let me just check how I'm doing for time. Am I doing okay? I will go through this. This is also hot off the press, so I'll try to keep it moving.
You're fine, Marsha. Please go ahead.
Oh, yeah. Okay, I think I'm good. So this is the new Cosmic 311. Again, hot off the press. This was presented at ASCO. This is the newest phase 3 randomized controlled trial. It was to ask the question, is cabozantinib following either lenvatinib or sorafenib an active agent for patients with second-line differentiated thyroid cancer? We knew from phase 1 data and a phase 2 trial that I did that this was an active agent. And so we wanted to find out and do the registration trial so that if it was active, we could get it through the FDA and EMA, et cetera. And so this trial was presented at ASCO. If you want to see the whole presentation, it's online there, and it's all recorded for you there. You get to see yours truly again. So progression, oops, sorry, hold on. Okay. So here you see the progression-free survival. Point out here, placebo arm, look at how fast these are progressing, 1.9 months. By the first scan, they had already reached resist progression. Why? Because after they progress on either sorafenib or lenvatinib, these tumors are growing quick. Okay, so that tells you that if you have patients who progress on one or the other, you have to be right away ready with that next line of therapy because they progress really rapidly. And in fact, the investigators were startled by this because sometimes many of us had patients who couldn't even go on the trial because they weren't able to wait long enough for the randomization, even though, and we had to really condense that randomization down to like 1 or 2 weeks because these patients really took off. So as soon as the sorafenib or lenvatinib is done, now that I have this data, I start them right away. I give them a week and I get them right on cabozantinib, no more than that, because they will progress rapidly when the lenvatinib or sorafenib is stopped. But what do you see here? Here, the progression-free survival wasn't reached, but it was statistically significant. And this study actually reached the primary endpoint at its first interim analysis. The study was shut down and no more randomizations occurred because it had already reached its primary endpoint. So this was stopped early at only at the first interim analysis, which was 6 months after the 100th patient was admitted. So for that reason, More data was presented or will be presented this weekend. If you want to know exactly what the PFS is for Cabo, that did mature in the newest data set, which will be presented this weekend. But you can see that already it's already out to, you know, somewhere in this bar between 9 and 18 months. Okay, so I can't tell you what it is because of, you know, top secret and all that. But go ahead to the ESMO website and you'll be able to find out now what this number is. But because of this, it was already statistically significant. The trial enrolled no more patients, and we just followed the 100. Actually, 100 patients had made it to 6 months, but there was a little over 200 patients who had been on the trial. Those are now the patients that are continuing to be followed. What is the response rate? 76% for cabozantinib, 29% for placebo. And these are just people who had kind of a little bit of waffling and maybe a little 1 or 2 target lesions. These were not durable, these little responses here. So we had a good response curve here for cabozantinib, 76%. Remember the 12% for sorafenib? And I told you that in good hands, at best, I'm usually seeing about 20%. We had 63% for lenvatinib, 76% for Cabo. So these are like in a whole nother level of response rates. We can't compare them side by side, but I think it would be, it's unequivocal that this is a very, very active drug in advanced differentiated thyroid cancer. This has been approved for medullary. This is the first data for differentiated thyroid cancer in a randomized control registrational trial. So now where is my algorithm? This is my algorithm. Lenvatinib, sorafenib, first line. Sometimes you can go back and forth if you feel like it, or you can just go lenvatinib right to cabozantinib. This is the first time we had documented proof that the responses in cabozantinib after lenvatinib. So remember, one of our concerns were what happens, can sorafenib really make a response after lenvatinib? We don't really have good data. We have case reports of it, but this is the first time we see cabozantinib after lenvatinib, and the response rate was in the 70s. So everybody can be reassured that there is now something good to happen after lenvatinib. So what do we do next? Now, the 2010s were the multi-kinase inhibitors. The 2020s is the decade of the selective kinases. So we have laro and entrectinib for TRK fusion, selpercatinib, pralsetinib for RET fusion, and pralsetinib was just, it's not EMA approved yet. But all 4 agents, minimal grade 3 or 4 toxicity. So I would never say that I would put an agent that's not a phase 3 registration trial ahead of a registrational trial agent, except in certain circumstances, and this is one of them. When the side effect profile is so much superior, I think it's fair to say maybe we will go ahead. You can't directly compare them because there'll never be enough, big enough study of TRK fusion cancers, which only happen in 5 to 25% of differentiated thyroid cancer, or 20% RET fusion, right? At most. And they tend to be, the fusions tend to be in the younger patients. So what do we have? This is larotrectinib. Look at how selective this is. It really just hits TRK A, B, and C. It doesn't actually hit any other VEGF receptor inhibitors, JAK2, or other inhibitors in this part of the kinome. And its fusions are estimated to be 5 to 25%. The light green are the thyroid, and you can see in larotrectinib, almost all of them, over 70% of patients had amazing responses, okay? I'll tell you, entrectinib had a little less number of data in thyroid cancer, but also, I think it was at least in the 50s to 60% response rates. Selpercatinib, RET fusion positive thyroid cancer, again, response rate of 62%. Selpercatinib progression-free survival, some of them haven't even been reached yet. And these are people who've been on drug for 2-3 years, okay? So PFS clearly is out there as long as lenvatinib or cabozantinib, and a much less toxicity. So those 2 things are the things I keep in mind when I'm choosing. This is pralsetinib in RET fusion positive thyroid cancer. Again, partial response rate of 91%. And again, people are out over a year on a regular basis. So now this is my algorithm. I do TRK fusion and RET fusion targeting first if the patient is a candidate. That's a big if. So that means that I have to test every patient before I start them on any systemic therapy. So I try to find out, do they have a TRK or a RET fusion? And I also check for point mutations. If I do next generation sequencing with RNA, I can find out, do they have a BRAF mutation? Do they have any point mutations like RAS or TERT or other things that I care about? And do they have these fusions, okay? So in one test, I can figure out what my treatment landscape is going to be. And so now my algorithm is what I call pre-first line, if you're eligible, first line lenvatinib and sorafenib, and cabozantinib soon to come, I think, for second line. So last, not approved or limited phase 2 data on the BRAF mutants. So where do I put them? Because there are some agents, and I think William knows of them. There are some sites. In fact, there's a single site that is very, very into BRAF inhibition. And they would argue that you should do this up front, okay? But should we? Okay, let's go to the videotape, right? What does the data tell us? The data set, so vemurafenib and dabrafenib are the 2 FDA-approved BRAF inhibitors. They were approved, they've been approved in melanoma. We know that BRAF V600E is present in half of thyroid cancer, mostly because most of them are papillary thyroid cancer. So this study was actually published in 2012. It was a multi-institutional international phase 2, where we looked at vemurafenib in patients who had BRAF positive papillary thyroid cancer. And you know, your site, your alma mater, William, was also on here, just so you know. So it's not, you know, they're all here, right? So they have to agree with this data. And basically this data showed that we have responses and we have progression-free survivals. Well, the progression-free survival on the left side is treatment naive. And now we were actually having, if we look at confirmed progression-free survival, it's about plus or minus a year, okay? It's not the 2 and 3 years we're getting with the selective kinase inhibitors that we talked about. And it's not 18 months that we're seeing with lenvatinib, okay? So it's shorter. And if we look in the second or third line, it drops down to 6 months to 9 months. So a lot less active here. These were heavily pretreated. These were not treated at all, okay? So this is the range, anywhere from about 8 months to about 15 months, okay? Response rates were disappointing. It was 26%. And then interestingly, it was identical response rates if you look at the dabrafenib and you look at the vemurafenib. I'll point out, please, when you see the dabrafenib study, it was already presented at ASCO. Be careful because they make it look like it's a 50% response rate, but that's because they changed the rules and they included minor responses. So they included all these people who had 20% responses, and it makes it look good on paper, but it's a little bit cheating because really at the end of the day, it was 9 out of 26 partial responses in both cases. So identical response, that vemurafenib and dabrafenib are equal as far as the response rates. Vemurafenib has a little less side effect profile as far as fever and chills, which seems to be a little bit higher with dabrafenib. So response rates are in the 26 is more right in the 20s to 30% rate, and a little bit lower progression-free survival. So where do I put that on my algorithm? I put it down here. Why? Because lenvatinib, cabozantinib, all of these are in the 60% or greater response rates. These are half of that. So we don't have better responses. And I would argue that compared to these, when you only have half as much of a response, the minor amount that these are a little bit more tolerable doesn't justify giving up half of your response. So, and also remember, this is phase 2 data. Most of the time when we go from phase 2 data to phase 3 data, those numbers get even lower. Okay, so that's probably an optimistic number, 26% or 30%. So in the end of the day, this is the algorithm I come up with, which I feel is completely data-driven and not from a biased perspective. So that's my, thank you for your attention. I was aiming for 7:50. I got 5 minutes ahead. So you might have questions because I probably spoke way too fast. And now I will slow down and take your questions.
This was perfect, Marsha. Thank you very much. You know, as usual, you know, I really enjoy your talks, and I think everyone here did. I have a ton of questions, and I'd like to invite Drs. Gustavo Pena and Gustavo Meyer to co-moderate this with me. And if anyone has questions, please go ahead and send them through the chat. Se vocês tiverem perguntas, mandem pelo chat, pode mandar em português que a gente traduz. So let's open up the discussion. Maybe we'll start with one of the Gustavos, and then I can ask my questions if no one has any.
Okay, thank you, William. Dr. Bros, I would like to congratulate you for the excellent speech, and it was amazing. And I would like to say that I am a head and neck surgeon. So as a surgeon, I feel myself as a fish out of water and that kind of subject. But I have a question as a surgeon, a question for you. I would like to know about your opinion in the cases of locally advanced disease Do you like that? Do you think that we are starting to be in the era of neoadjuvant therapy for locally advanced disease?
So I think you know probably the surgeons in the States and MD Anderson or at Penn, also here at Jefferson. My experience so far is these surgeons are so good, and I'm sure you are as well in Brazil, that I have yet to see a case that was not resectable at the beginning, that when I treated it was resectable afterwards. I think that the cases where people have said, oh, we say it's not resectable and now we say it's resectable, in most of those cases, when I show those scans to the doctors here at Penn, they would have probably resected them. So I think that when we really have non-resectable disease because the tumor is invasive and growing around blood vessels and things like that, we get nice responses, but we don't exactly clean off the blood vessels. The same things that made them not resectable are still there as not resectable afterwards. So if it happens, it's going to be extremely rare. And as I said, I've probably done it 20 times and have yet to see anybody clear up so much. Now, remember that was before. I'm not talking about TRAC and Laro, selpercatinib, those highly selective inhibitors. Those are different. We actually have some examples of sarcoma where people are actually, babies are actually having limb salvage surgery that they would not have gotten. So I would say the multi-kinase inhibitors and the BRAF inhibitors are unlikely to cause a non-resectable tumor to become resectable. The response rates just aren't good enough. But that's not true necessarily with larotrectinib, entrectinib, selpercatinib, pralsetinib, because I think that those agents are really giving us, I mean, I have a patient who had actually a mask salivary gland tumor, and he has a complete response. And he was told by a Sloan Kettering surgeon who's top of the line, he wasn't resectable. You have 3 months. It was growing around his carotid, right at the entry of the skull base. Go home, make your peace. In 3 months, you'll be dead. That was 5 years ago. He lived long enough to develop an esophageal cancer from the radiation he had had previously. A grade 1 has now been retreated for that with chemoradiation and is now cured a second time. Never would that have happened without something like larotrectinib. So I think are in the era of starting to see that, but it will be with those highly selective ones. It won't be with the BRAF inhibitors or the multi-kinase inhibitors. That's my opinion.
Okay, thank you very much.
Do we have the other Gustavo here on the line? Yeah, Gustavo, Pena.
Thank you. Congratulations, Dr. Bruce, for your excellent presentation. I don't have any question this moment. I prefer discuss this in clinical case.
Yeah, we'll go through the clinical case in a while.
Sure.
So maybe I should ask a couple of questions. Marcia, do you think that Cabo is going to make its way to first-line therapy?
You know, we'll never have a comparison side by side. We'll never have Cabo versus lenvatinib. And I don't think we really need it. I honestly think they're fairly equal. So since I think they're fairly equal and one was FDA approved in the first line and one was FDA approved in the second line, I do Cabo second. The reason for that is because we know Cabo works after lenvatinib. We don't know if lenvatinib works after Cabo. So if we had that data, then I'd say, yes, it could sneak up to the first line, not because we have a head-to-head study, which none of the companies will ever pay for, but because it has shown that lenvatinib can act in the second line. But for years before this study, I was using Cabo as a cleanup drug. I was having patients who had been on every trial I had, 5 lines of therapy. I had nothing else to do. I would get Cabo off-label, and they always responded. I had a patient who came to me, had multiple radiations for cranial metastasis, gamma knife 3 times, and then whole brain radiation, seizure disorder, came to me looking terrible. She only ever at best weighed 99 pounds wet, and now she was down to 70, looked terrible, and I had nothing else. And she wanted to try one more thing. Her mom wanted to, and I got compassionate use. And the day she came in, it took me 2 weeks or 3 weeks to get the compassionate use. When she came in, I think she was having a partial seizure because she wasn't even verbal. And her mom was just looking at me like a deer in headlights, just terrified I was going to say, I'm not going to treat her. But I had the bottle in my hand and I said, look, here's this bottle. I'm not letting my nurse come in. And we're just going to say that she's having a very bad day because her, performance status at that point was 3.9. Okay. And so she went home and had her bring her back a week later and she was talking. And 2 weeks later, the patient was giving me a hard time. So what was amazing is that even though she had radiation, it was clear they were still there. They hadn't shrunk a ton. They weren't growing anymore, but they were still there. With Cabo, she got 9 more months in a person who I would have even given her 4 weeks to live. And all of those CNS metastases, interestingly, shrunk. So I think we're seeing another kinase that can get through blood-brain barrier, which is probably disrupted anyway. But my point is that I had several of these disasters and I put Cabo in them and they would get 6 to 9 months more. So I think Cabo is active and it's active regardless of whatever a patient has had before. And that for that reason, it will stay for me in the second line.
Excellent. And I also, I think you made your point very clear about the BRAF mutations and the use of BRAF inhibitors, at least as monotherapy. And I totally agree with you. Do you use other information on next generation sequencing to make your treatment decisions? I think, the track and the RET fusions, this is very important. And I think, it's very obvious. But what about the rest that we see in thyroid cancers? Do you use that at all? And how do you?
I do. So I'll tell you where I use it. So RAS mutations are bad. We all know that. But it affects me when I'm treating because it means that where I might have with sorafenib expected 10 or 11 months, I'm going to get 6. Now, we actually did the analysis that showed that even in RAS mutant patients, lenvatinib and sorafenib still show improved PFS. So in other words, they still, in those groups that are worse off, they still show statistically significant benefit. So the reason I use it is that just tells me I better be ready with that next drug at 6 months. I can't sit back and relax and think these guys are going to get a couple of years. Similarly, TERT is another one I would keep an eye on. And then the AKT pathway, I also keep an eye on. Why? Because we know that more of the mutations they get, they're more likely to become anaplastic. But interesting, the ones that become anaplastic more often during therapy are the ones that are the BRAF mutations. So I keep an eye on the BRAF mutations, even if I'm not treating them up front, because I've had several patients, and probably, I should write it up. It's probably about 8 patients now that were on so many therapies that eventually they showed up with anaplastic. And interestingly, they showed up with anaplastic in bone metastasis. So those patients, I would then start on dabrafenib, and they did great, or on vemurafenib. Some of my dabrafenib patients don't tolerate it, so then I'll switch to vemurafenib. If they're anaplastic, I'll always use dabrafenib first, because of course that's the one that's FDA approved. But I've been able to get vemurafenib off-label. That's been fine too. So BRAF mutations clue me in. And then PI3 kinase, I did a trial, and we still are, again, I'm behind on writing up my papers, and I apologize, but it was presented in abstract form at ASCO, where we showed that if you had somebody who was on sorafenib, for instance, and you added in at the time of progression everolimus, we found that those patients did very well. Why? Interestingly, not because of genetic analysis, although those patients with PI3 kinase mutations did very well. All the patients did well because it seems that at the time of progression, there seems to be a dynamic upregulation of the AKT pathway. So we kept sorafenib on and just added on everolimus. And we were able to do that fairly well tolerated, and the patients did great. So, and they got another year. Okay, so you keep on buying yourself a year, there are good things there. So I think those are the main ones I'm looking for right now. Of course, we're always looking for the next oncologic related one, like could be an oncogenic driver that's has oncogene addiction. But the other pathways I think are important as well, even if they're just as prognostic factors. They do tell us what direction the disease might go while you're treating them.
And you just mentioned the dabrafenib trametinib for anaplastic thyroid cancer. We actually have a question from Cicero Martins asking about the dabrafenib trametinib or combination of BRAF/MEK inhibitors in differentiated thyroid cancer.
Yeah. So the differentiated thyroid cancer data was disappointing. It really showed, first of all, that the combination was no better than the single agent. So that's interesting. It was actually more toxic. It was more toxic, and the overall response rate was no different. So that tells me right away we should not be doing a doublet. If we do anything, we should do dabrafenib by itself. The problem with the anaplastic study was that they only had one arm, and it was the doublet. So basically, because it's approved, I buy both of them. And then within a minute, when they get their fever, I drop the trametinib right away. So most of the time, because I don't think if we had had that same data in the anaplastic, I don't think the MEK inhibitor is doing anything. But in anaplastic, we start the doublet. In differentiated, the data was poor. There was a randomized study out of Ohio State with Manisha Shah. And I think Maria Cabanillas helped write that up, where it showed that when you randomize between dabrafenib or the doublet, dabrafenib was just as good and less toxic. So there is data, but what I said before is that that data is similar to the vemurafenib, and it still goes to the bottom of the pile.
Excellent.
William, may I?
Wait, sorry, Alini?
I would like to ask a question.
Oh yeah, go ahead.
Dr. Marcia, thank you for your speech. I would like to ask you, in a patient with few metastases and asymptomatic, what's the best time to start the tyrosine kinase inhibitor? Mm-hmm. And about the dose of iodine, do you think we should still use 600? We need to wait 600 to start?
No.
What's the
No. Yeah, not at all. So the 600 was there in case there was somebody from Italy who was very excited about giving lots of radioiodine and had gotten up to 1,000. But the reality is that virtually all of the patients on all of these studies had already defined radioactive iodine resistance on the basis of growth following a treatment or no uptake. So even though that was a criteria, we never reached it. Patients had already reached one of the other endpoints. So the average radioactive iodine that patients on these studies receive is 400 millicuries. So we don't go to 600. They're already defined as radioactive iodine resistant before then. So that's that answer. As far as timing goes, I was alluding to it at the beginning of the talk, Marcia, when I said...
I'm sorry to interrupt you, but can we hold that answer to the case? Because I think one of the questions on the case is going to be that one. So
okay, I don't want to ruin the next part.
All right, excellent.
But that's a good question. Nice of you to give it to us. A perfect segue.
And what about redifferentiation therapy? Do you think that that's really an option?
No.
No, right?
So I think we've been trying it for 10 years and it just has not been shown. We've had case reports and a couple of case series, but every time we have a well-designed clinical trial to ask the question, it's been negative. We had a full phase 3 randomized trial that showed there was no benefit in the high risk patients. The other trial was definitely disappointing and has not been shown to have any benefit. So no, I just don't think we have data. And I think it's just wishful thinking. I mean, at the end of the day, we're not going to turn back the clock on these patients. Even if we're able to temporarily, and I'm a cell biologist and a geneticist, and we all know that if we can turn something down, that's not going to change the whole cell. It's just turning it down temporarily. And so while it looks very nice in cell culture, and I applaud Dr. Fagan for his work, sadly, I think it's one of the things that I don't think it's going to translate. And the sad thing is that so many people are saying that they're doing it. So as you know, at your institution, they're doing it like crazy and the data isn't there. So unless you're at MD Anderson or a couple of endocrinologists who follow that philosophy, most of the rest of the country are not giving it because we do not feel that the data warrants or supports it. And by the way, the MEK inhibitors or the BRAF inhibitors are not without side effects. No. You can get cancers of the skin, you can have all sorts of other things. So it's not, let's just give it. BRAF inhibitors, they're fine. They're not fine. And they have side effect profiles. And I don't think we should be giving it without a good randomized trial, or at least even a good phase 2 that shows something that we can believe. Even if you take Dr. Ho's example of the original pilot, and I was actually asked to be the commentator at ASCO when that was presented 10 years ago. If you look at it, out of 20 patients, only 12 had increased uptake. And out of those 12, only 8 had enough to actually treat. And out of those 8, they had a little bit of response, but so would 5 weeks of a MEK inhibitor, even without radioactive iodine. But they didn't take that into account. So those responses, they said, were due to the radioactive iodine. But we know from Ezra Cohen's work that he did before he left Chicago that drug, the MEK inhibitor, will cause that kind of a response on its own. So nobody's putting like the whole picture together to realize that what they keep on saying is radioactive iodine completely be described or explained by just that short-term effect of the MEK inhibitor.
Excellent. So maybe we should go to the case, because I think the case is very interesting. If we could have you for a few more minutes, and then we'll get that question answered about Aline. So Gustavo.
Okay, thank you. The slides are in English and I will speak in Portuguese, okay?
All right.
Então, para os colegas que estão assistindo, essa foi uma paciente que, na verdade, foi encaminhada e chegou agora no consultório em 2021. É um paciente, é um homem de 60 anos que teve um diagnóstico nessa época de um papilar variante células alta, multifocal, e fez uma tireoidectomia total com esvaziamento cervical central e lateral. Tinha 9 metástases na cadeia central e lateral. Essas metástases eram menor do que 2,5 centímetros o foco, e não tinha relato, ele não trazia esse relato, só o encaminhamento da colega, se tinha extensão extranodal, extracapsular ou não. Foi feita uma primeira dose terapêutica com iodo nesse paciente, de 200 mg com TSH recombinante, e a PCI pós essa dose terapêutica não mostrou nenhuma captação anormal, só em leito cervical mesmo, inclusive faltava essa informação. Pode. Em 2016, esse paciente fez um PET, que mostrou só micronódulos inespecíficos, sem nenhuma atividade metabólica, nenhuma atividade glicolítica ali, e fez uma nova dose de radiodo de 200 mg, novamente com TSH recombinante, e mostrou uma captação em mediastino e uma captação leve em ambos campos pulmonares, nessa segunda terapia. No acompanhamento, tinha relato, nessa tomografia de tórax, já apareceram alguns nódulos pulmonares, aqui estavam descritos os maiores, mas já com o início de uma distribuição randômica, assim, de micronódulos pulmonares, e os maiores descritos nesses sítios. Em 2020, ele repetiu esse PET, que mostraram 2 nódulos já com uma atividade, um hipermetabolismo nesses nódulos, com o SUV aí num deles baixo ainda, de 1,7, mas no outro acima de 5, né, de 5,8, nesse nódulo no lobo superior esquerdo. E foi feita uma terceira dose de iodo, chegando no total, que a Aline mencionou anteriormente, 600 mg, também com TSH recombinante, e esse PET a varredura pós-dose, nesse último iodo, mostrava uma captação importante no mediastino superior em ambos campos pulmonares. Então, é dessa forma que esse paciente chegou até mim, com essa história.
Então, can you go back? William, can you just answer a quick question? Between January and June, did they have more lesions found in the lungs? Like there was more growth? Like there are more nodules?
Entre janeiro e junho, apareceram mais nódulos no pulmão?
Não, no que tem relato, não. É bom, você fala para ela, William, que, na verdade, chegou isso tudo num relatório. Eu comecei a segui-lo agora, né, no início de 2021, mas não tinha aqui relato nesse intervalo de terem aparecido nódulos entre esses 2 exames.
So Gustavo only has access to the medical reports. He wasn't following the patient at the time, but apparently no. Apparently They were stable.
About the same.
Yeah.
Bem, aqui, então, nas imagens, a gente vê que tem micronódulos pulmonares que não captam, talvez pelo tamanho, não tem atividade ao PET, né, atividade metabólica nenhuma, mas tem 2 nódulos com uma atividade mais acentuada ao PET, esse de janeiro de 2020. Esse paciente, agora que chegou em mim com uma tireoglobulina basal, né, com TSH baixo de 43, e ele repetiu o PET agora, que apresentava um hipermetabolismo e aumento nas dimensões desses nódulos. Então, agora, esse nódulo que tinha o valor do sub de 5,8 foi para 8,6, e eu acho que está cortando aqui o de baixo, mas também teve um aumento da atividade dele ao PET. Isso a gente evidencia aqui nas imagens, então, a gente vê que a captação foi mais intensa nesses nódulos e que eles cresceram um pouco, mas que houve um crescimento comparativamente com o PET anterior, nesses últimos, né, comparando os 2 PETs, o PET de janeiro de 2020, né, nesse ano e meio, e o PET atual, que mostra esse aumento desses. Então, se a gente não está com o meu, eu estou pondo a seta aqui, mas na verdade não sou eu que estou comandando essa, mas a gente vê essa diferença entre essas captações. Então, pode passar. Então, um resumo do caso é esse: um paciente que em 2014 teve um papilar variante de células altas, fez uma tireoidectomia total com esvaziamento ganglionar com metástases grandes, cervicais, fez 200 miliquiri à época, sem nenhuma captação anormal na primeira PCI. Em 2016, apareceram nódulos pulmonares inicialmente interpretados ou abordados como inespecíficos, fez uma nova dose de iodo, que mostrou uma captação leve na PCI pós-dose, e em 2020, ele tinha já esses nódulos com leve hipermetabolismo ao PET, fez 200 miliquiri, e aí mostrou uma intensa captação, tanto em mediastino quanto em ambos os campos pulmonares, em ambos os pulmões. E agora, em 2021, vem com essa TG basal de 43 e um aumento desses nódulos pulmonares e um aumento da atividade metabólica dele ao PET. Então, na discussão, William, eu falo em português, você não tem coragem de falar inglês perto de você. Aí você passa para ela. Então, a primeira coisa, essa tireoglobulina, talvez a gente não possa interpretar ela muito ao pé da letra, porque pode estar havendo já uma desdiferenciação aí desses tumores, e se pensar em metástase à distância, a gente poderia esperar, mesmo uma tireoglobulina basal, muito mais alta do que essa. Mas a dúvida nesse paciente é o seguinte: esse paciente chegou em 600 miliquiri, mas a última captação dele ao PET foi uma captação muito importante, uma captação intensa e forte no último iodo. Então, qual seria a conduta nesse paciente? Será que valeria a pena uma PCI diagnóstica? Porque lembrando que ele teve, a gente sabe do fenômeno flip-flop lá, né, que troca o NIS pelo GLUT, no receptor, então ele se torna iodo refratário por isso. Mas será que valeria a pena uma PCI diagnóstica, a gente avaliar mais atividade, mais dosagem nesse paciente? É uma primeira questão. Outra, o paciente está assintomático, mas claramente progredindo doença estrutural. Valeria a pena só manter o segmento, não fazer nada nesse momento? E uma última, entrando nos marcadores moleculares. Em relação à tirosina quinase, eu não acho que é o momento de entrar nesse paciente. O paciente que está completamente assintomático, uma vez que a gente sabe dos seus efeitos modestos e dos riscos importantes de efeito adverso. Mas valeria a pena a gente fazer estudos moleculares pensando em terapia-alvo, que aí a conversa é diferente, né? O resultado é melhor, que tem se mostrado, e os efeitos colaterais muito mais discretos. Então, a minha conduta, se eu tivesse uma mutação, por exemplo, um N-TREC aí para usar larotrectinib, sabendo ser raro no adulto, mas ou um RET para fazer o salpercatinib, ou outro alvo, eu já pensaria em entrar nesse momento. É isso que eu gostaria de escutar da doutora Bruce.
All right. So, Marsha, let me try to pose the questions here. And if we need to go back to any details of the case, we can go back. So the first one would be, how reliable this thyroglobulin would be, because the patient has metastatic disease. Is this the level that we would expect? Should we be expecting much higher thyroglobulin? Is this already an indication that maybe the tumor is de-differentiating? So that would be one question. The second question would be whether we should be doing a radioactive iodine uptake scan to see what's going on and see if this patient could even get more radioactive iodine, or should we just consider that this patient is refractory at this point? And if it is refractory, is it the time to start therapy? Because we do show that there is an increase in size as well as uptake of the PET-CT. And also whether we should be doing NGS to look for targeted use of targeted agents at this point.
So I'll take the last one first. Yes. So we should be doing NGS because this patient's not been cured. And so you're going to need to know. And most of the genes that we're looking at are probably initiating events. So even if you can't get any tissue from a metastatic lesion, the tumor from the primary would probably be sufficient to get you the answer. So the only problem is the primary tissue is over 2 years old, and doing RNA NGS is not usually reliable if the tumor is over 2 years old. So I would start thinking about, is there a nodule somewhere you might be able to get? Don't really see them on the scans that you showed, but maybe there's one that I didn't see on another level. The second thing is, let's go back to the thyroglobulin. So I think that he has a low burden, or she, I didn't notice it was a she or he, but they have a low burden of disease. And I think that's most likely why the thyroglobulin is not that high. But at the end of the day, a thyroglobulin only means something to the patient who it has. So what we care more about is the change in the thyroglobulin, not so much the total level. So what I care more is from year to year, is it going up very slowly or is it doubling? And what is the doubling rate? So I'm on a paper with Mike Tuttle, but I will tell you that I disavow doing doubling time on the size, because in oncology, that's not he was talking about a doubling of diameter, but doubling time has a very definite meaning for oncologists, and it means doubling the number of cells. And if you know your geometry, the doubling of the diameter is not proportional to the doubling of the size. So rather than get into a discussion about that, we can talk just about the doubling of the thyroglobulin. It is true that if somebody is doubling and it's over 2 years, they're growing very, very slowly. These people I can often let go until the larger lesion is 2 centimeters or maybe more if it's right in the middle of the lung. What I don't like about your patient is that nodule is right on the cardiac border. And it's clearly involving the pleura. So the concern I have is the longer you wait to treat that patient, even though treating that patient now I would consider early, I usually would let them go longer. But the reason that I sometimes treat them, I wouldn't let them maybe go too long, and I'd be keeping a close eye on those CAT scans every 3 months, is it doesn't take much for that tumor to cause a pleural effusion. Once a patient starts having pleural effusions, they have much pain, they have morbidity, they can collapse the lung. And even if you get the fluid out, sometimes it doesn't all go away. That said, with lenvatinib, I've had some patients who stayed until they had a very little effusion. I started it right away, the tumor shrunk and the effusion was absorbed. So you could watch this, but if you let it go, you have to scan them every 3 months, because you don't want to let that effusion, as soon as you start seeing any fluid in a very small lens shape, you would want to start, because by the time a month goes away, or even a week, that could turn into half the lung. And when you treat the tumor, the protein that it's secreting into the pleural space, when you treat it, those cells burst, and then you have even more molecules to absorb water. So if it starts to have effusion, you're more likely to have an increase in the effusion after you start therapy than if you were to wait. Than if you were to treat earlier. Okay. So you have to, in your mind, be thinking that they're going to get a little worse before they get better. And don't leave them to the point where if they had symptoms, you don't want them to have symptoms, because if they got worse, that's not good. Or that they are at risk of having symptoms, so that if it got worse, you could tilt them, push them over the edge into having bad systemic treatment bad systemic disease. As far as size goes, if they're in what I would consider safe areas in the middle of the lung, not hitting the pleura or any segmental pleura, I might let them go until they have a lesion that's 2 or 3 centimeters. But what I pointed out in this trial is that the requirement was a centimeter large, and it was progressing by 20%. So I think if I remember this measurements in 2020 and 2021, you had exactly 20%. Like you had the minimum. You went from 10 millimeters to 12 millimeters. That's the minute, and that was the only measurable lesion. So that would be the absolute minimum of a patient that could go on that trial. And remember, there was a little bit of a tail, so that patient's more likely to be in the tail. So I might let them go a little bit longer. In the sorafenib study, we know that if they were between the largest lesion was between 1 centimeter and 1.5 centimeters, wasn't so much of a benefit. But in the lenvatinib study, even if they had the biggest lesion was only a centimeter, there was clearly a benefit. So what you need to know about your patient is they're eligible now. When you start is between you and the patient. Sometimes the patient may have a wedding of a dear son or daughter. You don't necessarily want to start them on this medicine a week before or a month before that. So once I would have a patient in your situation, I would say to myself, I need to have a conversation with the patient and say, you need therapy in the next 6 to 9 months. How do you want to do it? Do you want to wait till after Christmas? Should we do another scan after the new year and make that your new baseline and then start after the new year? The beautiful thing about thyroid cancer is it's not growing so fast in most cases that you have to start urgently. So now you can have a little discussion and figure out the timing. I love the summer. Most of the people in my area love the summer. So it's very common that I start patients on therapy in September. Like if you were to look at all of my patients, probably half of them start in September. Everybody's grumpy in September. Down up here, the school starts in September. Everybody goes back to work and there are no more vacations. So might as well start your therapy. Okay. But that's really true. Like, if it were you, would you want to start lenvatinib right before your son's, first birthday? Probably not. So you can have a decision there. A little bit of flexibility, but they're probably going to need it in the next year for sure.
And what about a new iodine scan?
So I always get iodine scans every time we give iodine. And the reason for that, and interestingly, now that we have these drugs, I think that when they have metastatic disease that's not been cured by 1 round of radioactive iodine, every time from now on that they get radioactive iodine, they should have a diagnostic either a PET CT, or if they've had a PET CT, a CAT scan. Because you may do a radioactive scan and say, oh, these 3 or 4 nodules took up radioactive iodine. But look over here, there are 8 more that didn't take up iodine. At that point, you can ignore the ones that took up iodine because they're not going to cause any trouble. And now you can focus on the ones that didn't take up iodine and watch those. The ones that took up iodine are likely going to stay the same or not necessarily grow that much. Now that there are exceptions because there's heterogeneity. Even within a single nodule, you can have cells that don't take it up. But in most cases, the nodules that don't take up iodine, those are the ones that will cause problem.
Aline, did we answer your question?
Yes. Is there a place to stereotaxy radiation therapy for thyroid cancer, as in this case? What
Yes. So if I had a patient like Gustavo's patient that was doing so nicely for many years, that would be honestly a case for if it turns out, okay, so say we had done a scan at the 3rd radioactive iodine, which was in 2017, 2016, maybe? Was that 20 or 2020? The
Quando
last
foi,
radioactive,
Gustavo, o terceiro radiodo foi quando?
the last one,
20, foi 20.
2020.
2020. So at that time, I would probably get the radioactive iodine scan and a CAT scan right away to correlate whether the radioactive iodine lesions, whether there were lesions on the CAT scan that were not on the radioactive iodine. Because if they have metastatic disease, you're going blind to only look at the radioactive iodine scan. And you don't know the function of the radioactive iodine if you're only looking at the CAT scan. So you need to have them side by side done. First the radioactive iodine, and then we get a CAT scan with contrast the next week. So we can directly compare. So I think that there's a role for that. Now, remember, there's this whole idea of don't give more than 600. There are exceptions. There are exceptions to every rule that I've said. And the reason I say them as rules is because you shouldn't break a rule unless you have a good reason. Now, in Gustavo's case, his patient has done well for, almost 10 years, if I remember right, when the first diagnosis, right? So the patient gets 3 or 4 years every time they got radioactive iodine. You could argue that you could give him one more dose. Just remember that when you start to go over 600 milligrams, you're more likely to get problems with leukemia. And I've had 4 leukemias in my practice, and they all came from patients who had over 600 millicuries. So I think that you shouldn't be giving it unless you're pretty sure that you're going to get another 3 or 4 years. So that's question number 1 for breaking the rule about 600. Then there's also the rule that says you should treat people below 1 centimeter because they were not allowed on the clinical trial. Well, I gave you the example of if they have disease along their pleura, and you have to look at that pleura, like that guy has invasion of his pleura, no question. I would be going up and down his scan, looking at the edge very closely, or even more importantly, looking at the septa between the lung lobes, interlobular septa. Because if you see little dots that look like little pearls on beads on a string, you have pleural-based disease, and it's probably 10 times greater than you think you have because it's spread out over the surface of the lung. Those people need to be treated right away. And I don't care if the biggest lesion they have is only 3 millimeters. If they have that, I don't wait because I don't want them to get those pleural effusions. And putting in Pleurex catheters, terrible for their quality of life. So for every rule I give you, I have an exception, right? I've given you the exception. Just like I said, the starting dose and using lenvatinib first. The exception to that is if I have invasive disease. So those are their tricks. But I think if you go with the rules, you'll be right 98% of the time.
Excellent. I think Thiago has one last question, maybe a comment, and
Yes.
I think we're running out of time. So Thiago, you have.
Yes, just a quick question. Does the presence of a target like RET or NTRK influence your decision on the timing of treatment initiation?
Well, you could say that because
start treatment earlier.
Yes, because you're not worried about the quality of life changes. Exactly. No. So no matter how well tolerated it is, it's a burden on a patient to be on these therapies. And so I would prefer, I love drugs and I love genetics. My PhD is in genetics. I love targeting genes. It's my favorite thing to do all day, twice on Sunday. But the problem is that no matter how much I love to do it, no drug is still better than a well-tolerated one. So I feel that now that I know I have these tools in my disposal, that it's my responsibility to the patient to say, what would I want to do? And I'd want to have my drug-free life last as long as possible. Because once you start the medications, you'll need to continue. And so I feel like now I get very protective of my patients, like they're my mother or my brother or my sister. And I won't give it to them unless I feel that they're going in a direction that I don't like.
Marsha, thank you very much. This was really enlightening. I think we all enjoyed. Thank you so much for spending this time with us. And maybe I should give Thiago and Aline the last few words. Thank you so much.
Next time in
agradecer,
person.
então, a todos. Yeah. Thank you, Dr. Bros, and presentes, e passar a palavra final à Aline. Boa noite a todos.
Pessoal, muito obrigado pela presença. Gustavo, Meyer e Pena, muito obrigado, foi ótimo, parabéns, assim, obrigado por nos estimular. Márcio, thank you, it was excellent. Muito obrigada a todos que assistiram. Convido a quem não é do Grupo Brasileiro de Câncer de Cabeça e Pescoço, então, os endócrinos aqui, entrar é gratuito, é só entrar no gbcp.org.br e fazer o seu cadastro lá. A gente tem aí várias atividades o ano todo e estão todos convidados a participar do grupo. Muito obrigado, boa noite. William, muito obrigado. Tiago, foi ótimo. Obrigada, pessoal.
Obrigado. We'll see you in Brazil next time, Marcia, in person.
Ok, obrigado.
Bye.
Gracias.
Bye.
Boa noite.
Boa noite, obrigado.
Boa noite.